Dr. Sykes, thank you so much. It's a pleasure to be here today and talk to this group. Um, today, as Dr. Sykes says, we'll focus on a little bit of introductory stuff around informatics and how it applies to a learning health system or a learning collaborative like the STEP-LC. So I came to you. I am a psychiatrist by training, but I come to you with my informatics hat on. And again, as Dr. Sykes said, I think we'll have plenty of time for questions at the end. So I'll get going. Today, I hope, first of all, I hope my PowerPoint works okay. There we go. Today, the main bullet points we'll be covering is some introductory material, basically some definitions around informatics, thinking about some of the core functions of a learning health system and maybe how these two are paired together. Looking at some examples of informatics in practice, both outside of the early psychosis setting as well as things we're doing on the STEP-LC. Looking at the specifics of STEP data collection and then areas and ways we've been able to apply that through the informatics core to gain insight around our care and how to improve things for folks we're treating. But first, I think it would be really helpful if you allow me. There's a 4-minute introductory animation-based explanation of the STEP-LC that I am fairly certain I could not improve upon as far as kind of setting the framework for the big picture of this kind of work. It really sets the setting for why, say, for instance, an informatics core is so important. So if you'll allow me, I'm going to actually play this wonderful animation. And then, like I said, it will set kind of the groundwork for our discussion moving forward. But hopefully, this is a big fingers crossed, the video will play okay.
Psychosis. It's a scary word, but here's the thing. Psychosis is treatable. The earlier it's caught and treated, the better the prognosis. Psychosis is an early warning sign for schizophrenia. Unfortunately, many people face delays in getting the help they need, which leads to poorer outcomes. Disorganized systems often send these individuals down a pathway that delays immediate treatment, prolonging the duration of untreated psychosis. There are many key players that can unintentionally misdirect someone in crisis toward jail or a distressing and unnecessary ER visit before finally, potentially, getting help. Key players are all around us in our community. However, a shift in perspective can empower these players to actively become part of the solution instead. That's where the STEP Learning Collaborative comes in. STEP Learning Collaborative is a network of experts, clinics, and community members working together to reduce the time it takes for individuals to receive psychosis treatment. It all starts with a single call. Anyone can call. A patient, family member, clinician, coach, anyone can reach out to the STEP Learning Collaborative referral line. They'll speak with an early detection and assessment coordinator who's especially trained to help. The coordinator connects the patient to the right clinic within one of 5 regions in Connecticut. From there, the coordinator addresses individual barriers that a patient might experience. This might include any issues a patient has with making it into their initial appointment with the clinic. The coordinator then monitors their progress via survey. But that's not all. The learning piece comes into play because STEP Learning Collaborative is designed to be a learning health system. That means it's not just about providing care, it's about learning from every patient experience to continually refine and strengthen the system over time. We use detailed assessments of patient outcomes across the network to determine what's working and what's not, to guide continuous improvement. And here's what makes it even more powerful. Multiple work streams are running in parallel, all working towards the shared goal of improving the system and ensuring everyone is learning how to improve the patient journey together. These work streams include educating community members, clinics, and family members to help with early detection, research to develop new treatments, assessment to continuously improve access and quality of care, and building sustainable and cost-effective models of care. At the heart of it all is the patient. Every learning activity is grounded in the patient's experience with the goal of delivering more effective, compassionate care. The patient is not just the beneficiary, but the source of the insights that drive continuous improvement. The goal? To enhance access and quality of care by organizing a network of stakeholders into a coordinated system where everyone, from doctors to families to community members, work together to guide people towards the care they need faster and continuously collaborate to improve the quality of care. The result? A more responsive, coordinated system where people facing psychosis get the care they need faster, improving the outcomes for schizophrenia.
A lot of words here. I want to focus mostly on the highlights, though. Thinking about what really the key functions of a learning health system, what they are, and a lot of these were highlighted, I think, really well in the video. And thinking about patient-oriented, continuous learning and improvement, how we can monitor the cycle and collect really good quality data to use that to inform changes and improvements to the system. And then integrating any evidence and practice evidence of evidence and practice into our into the treatment cycle there, whether applying the things we've learned, integrating those into care. Being very data driven about our decision making, making sure that we're not necessarily just shooting from the hip, from a heuristic, from some anecdotal evidence from the past, or that doesn't necessarily apply to our cases or our cohorts, but really making sure that we're making decisions based upon real good quality data. And then being very thoughtful at all stages of development that clinician and broad stakeholder engagement are really driving the priorities of a system. Because as I think you see pretty quickly that, and we will have some more slides about it in a second, we have to be very careful about how we define, for instance, the primary objectives, the foci of improvement, and we want to make sure these are not defined simply by a small group, but are defined by a larger, broad stakeholder group of a well-represented group. Now, here's the pair of that. What do we think about when we talk about informatics? Technically, it has a nice, concise definition that it's really the science of using data and information and technology to improve decision making and through processes and outcomes. And especially, we think about it in the complex systems like healthcare. And that's definitely the context we're thinking about it now, although it's not exclusive to that. And it was kind of the back of the napkin representation of that is it's the process of taking data, which is kind of raw facts or raw data points that we might collect, passively from notes or from lab work or from surveys or assessments, and really changing those from into information, kind of more organized or kind of pared down version, clarified version rather, and then finally into knowledge, which we see as a really kind of human actionable insights from the information. And that knowledge, so to speak, are things that we want to both incorporate back into our learning health system, but also share with other practitioners like we are now as part of a learning collaborative. So it's really this idea of transferring and evolving data into knowledge, and then folding that back into our treatment systems. There are lots of examples of this beyond even the learning health system or beyond psychosis, but I think we don't necessarily have to go through all of these in great detail. But thinking about how informatics is a place in almost every corner of healthcare, from clinical decision making around sepsis alerts and drug interactions that many of us are aware of, even from our pharmacists saying, have you having an automatic pop-up saying, have you considered this interaction or being careful with these medications? Thinking about population health interventions, and we saw a lot of these COVID-19 dashboards, for instance, during the height of the pandemic, and how they were really helpful both, I think, in informing the public, driving policy decision making, helping folks get on the same page most of the time about next steps and policy stages there. Patient engagement, think about mobile apps for collecting and providing data, using informatics to predict, for instance, patient attendance to clinics is very valuable for both for patients and for providers. All the way to genomic analysis, operational efficiency, thinking about how to predict or bed needs, staffing needs. These are very important at a hospital level, kind of behind the scenes, but super important and greatly affect patient care, and also could be benefited by an informatics approach. And then, of course, as we see in our learning health system, thinking about dashboards to track and improve care outcomes. Once those outcomes are kind of clarified and defined. And even some more advanced stuff maybe down the pike, kind of using natural language processing to look at clinical notes and help them inform or rather extract important data and then into knowledge from a large opus or a large cohort of patient data. Now, what data we collect, I think is also super, super important. This is a little bit of a complicated figure, and I apologize. I hope we might pay attention to mostly to the left side of it, because really the idea here is, I think, realizing that very, very upstream decisions, like what outcome objectives, what kind of access objectives to monitor and really and aim improving, are super, super important for all stages downstream to that. And also how important it is that those objectives are defined by a broad collection of stakeholders. We see, for instance, this is the STEP learning health system informatics workflow that we kind of use internally and have been some of our publications, but they give an idea of how broadly we were thinking when we were, very early stage defining, what are we really going to prioritize as far as things we want to pay attention to, things we want to improve, either reduce, say, in bad things, or improve in good things over periods of time as we're evolving the clinic, and also as we're rolling this out into multiple settings. And that was the point that the stakeholders input, for instance, patients' families, service users and their families, their support systems, members, clinical and non-clinical members in the community, as we've seen, from police to educational to counselors in the community, and then also thinking more broadly around kind of funding structures and political structures around legislatures, payers, all sorts of very, very broad stuff. Or a broad collection of folks who had really, really valuable input on kind of these outcome measures of what we really wanted, what we want to focus on, and therefore what kind of data we'd want to collect and drive an informatics-based learning health system or learning lab. Early on, this converged on a set of access outcome measures that we have used internally to be the real focus of our kind of quality improvement measures, and these are grouped roughly into these big areas of access measures. How quickly we get folks into care, if our representation is equitable and it kind of represents what the general representation of the towns and states the state we collect from, and then also thinking about their pathways to care and how that influences their delays as well as their experiences into getting into care, and then subsequently both some baseline and some longer outcome measures around hospitalization, symptomatic remission, cardiovascular risk, smoking, obesity, metabolic factors, and vocational engagement, super important for a recovery focused and patient focused treatment plan as well. And so these really, from a very early stage, set the groundwork for what kind of data we want to collect into an informatics system like that we have developed. When is also rather important. And what things are collected at what point. And a lot of times we think about the timeline of data collection for those going through our first episode psychosis clinics as kind of heavily on the intake, where we're going to collect a lot of information around kind of our access measures, how long it took to get care from the estimated onset of illness to their enrollment into care, the pathways they took to get to that care, which is a rather idiosyncratic type of data to collect, and we'll actually have a slide in a second to think about how we have developed some solutions around that, because it's such important but difficult to kind of collect data. And then also thinking about our disparity analysis, whether or not the folks we're getting into the clinic really represent what we expect from a kind of a random distribution or random collection from the communities we serve. And then also, of course, at intake, we get our baseline outcome measures. So these are going to be the first of several ongoing collections of symptom status, service utilizations, if they've been hospitalized, if they needed, what kind of clinical interventions they needed on their way to care, thinking about their smoking status, their BMI, their metabolic factors, vocational engagement, if they're working, if they want to work, what barriers to work there have been, these kind of things. And then we'll have major sample points at the 6-month, 12-month, and kind of and depending on the layout of a particular collection schema, at points after that will be the major collection kind of sieves for a lot of our data. There, of course, nothing is ever that clean, so there will be points where, and these smaller little ticks are, where we're rolling in relevant data at other time points between these major sample points. But that's the kind of a collection modus we think about it. Again, these are intakes, oftentimes done, at a combination of of survey, of sometimes in-person assessments, sometimes online assessments. We have quite a bit of flexibility about how these are rolled out and how these data are collected, as well as the integration of external data sources, for instance, in areas like disparity analysis, where we have to know, it's one thing for clients to report to us or patients to report to us their, for instance, identified gender or identified socioeconomic background or racial demographic background. But it's also important to know, like for instance, from census data or from state data, what the breakdown of the areas from which we're collecting patients or recruiting patients, and if there's representative or if there's some disparity there that we'd want to know about and think about ways of rectifying. So it's a place of collecting the initial bolus of data of various modes and also integrating some external sources as well. Subsequent analyses subsequent data collection mostly focuses on kind of more the outcome measure things, because of course some of these access measures have already been ended as they enrolled into the clinic, and so we're focusing more on subsequent assessments around some of the other outcome measures like remission status, service utilization stuff, metabolic stuff, and these all get sieved in. But as I mentioned to before, there are some data types that are rather idiosyncratic. For instance, the pathway to care data is again very, very high quality, very, very important data, but rather difficult to collect. In fact, we went through multiple iterations over the last decade or so about how to collect these, and it finally, at least for now, converged upon a mostly computer-based visual interactive pathways to care collection instrument that has been quite helpful. Here we see three different kind of screen phases of the instrument that allows us to define a timeline based upon onset and enrollment data points, to visually click and add community nodes, clinical nodes, times for these enrollments. It's editable. It can change it if we make mistakes or if the patient remembers more data or wants to change data. And then this is all extractable into our main database, into a REDCap database, as basically as a plain text CSV entry, which allows us to do a lot of things, really sophisticated things downstream. One of the things we've been able to do is to look not only at pathways to care for particular patients, but start to look at aggregate pathways to care for a lot of folks who are traveling through our system of care, as defined by the local clinic, so to say. And it yielded, for instance, some of our initial analysis based upon some early step data yielded some really interesting insights, including identifying rather unexpected major sources of delay into specialty care that were rather surprising and allowed us to really tailor our interventions to other maybe community members who had not been the focus thus far, and subsequently allowing us to reduce DUP a little bit further, as well as making some pretty pictures, which is something I always like to do. Now, how do we put these data to work? Now, the Pathways to Care network graph we just saw is one example of that, and some analyses based of those aggregate data, again, as I've already alluded, was quite helpful in thinking about sources of delay and how to intervene again to lower that delay in the community setting within a system of care. Another thing it allows us to do is continuous monitoring of key outcome metrics. For instance, it allows us to look at our rolling duration of untreated psychosis over a 6-month period or so. It's a rather techie looking visualization, but the big idea is we want to make this hard red line go to or below the dashed 150-day line. And this is something that we've definitely decreased. If you look over left, which is earlier on in the clinic's enrollment, there were much higher numbers, and we were able to lower these. And there have been periods when we've been able to significantly lower and maintain them for significant periods of time, something we're quite proud of. And then also when these edge back up, it gives us an idea of when to focus on what things might have changed, and it also informs subsequent interventions into the system. And so this close to real-time monitoring of some of these key metrics are really, really important for the learning health system aspect of this, and kind of feedback into what's working now. Maybe it's not what worked in the past, so we need to kind of continuously monitor this stuff and iterate over and then being able to judge the results relatively quickly, and which is really, really important for the whole cyclical process. This is a rather straightforward visualization of some of these ideas about kind of equity of recruitment into the clinic. For instance, this is a graph that allows us to look at rather quickly look at the recruitment by race and ethnicity as compared to the our recruitment within the clinic as compared to the catchment area, the 10-town catchment area that this particular clinic was recruiting from, and statewide averages as well, to see where, if we're getting any discrepant representation. For instance, we happen to have a lot of Black or African American representatives within our local cohort here. They're actually overrepresented from the catchment area, and that's something that's interesting in our recruitment efforts, and informs some of our interventions around maintaining high enrollment from African Americans, but also thinking about ways to kind of normalize some of our recruitment efforts as well. It's an interesting metric or a method for monitoring kind of a moving target. Smoking status, as you might say, or as you might guess, is something that changes over time. Some of us never smoke, some of us never stop smoking, but there are those, especially in early episodes of psychosis, who are really struggling with tobacco use, and knowing where folks are within that spectrum, folks who have come off or on to smoking, is very, very helpful. And this allows us from an informatics dashboard to see, for instance, that we have it coded in red. For instance, here is kind of a heuristic for bad. We have a certain percentage of folks who are going from not using tobacco at enrollment to starting to use tobacco at 6 months, and these were folks we definitely want to focus in on smoking cessation efforts. Similarly, we had folks going from using tobacco to stopping, and so presumably the interventions of some of their clinicians to help them see the benefits of not using have been helpful and successful. And this allows us to see, again, in kind of a moving target basis, what as a clinic wide, as well as particular patients, where we need to focus on our efforts to make sure they don't acquire kind of a nasty health negative behavior. So this is another example of disparity analysis, where we actually get to compare, say, a particular subcohort. This, for instance, a cohort that identifies as interracial to the complementary cohort, basically everybody who does not identify as interracial within the cohort, and to see, just at a very kind of visual way, to see how similar or dissimilar these particular slices through the data are, and again to form ideas about similarities or differences, and how those might drive decisions on the individual patient as well as the clinic-wide scale. And so these were some examples of I hope, of showing how we think about the really intrinsic connection of the priorities of a learning health system, what we're really trying to do here: continuously improve, really integrate evidence and practice, making sure our decisions are data-driven, and making sure that our clinicians and a wide stakeholder representation are involved in the outcome measures. And also how informatics as a kind of data into knowledge engine is really, really integral in I think just about every step of the learning health system as well. And I think, yeah, that actually just wraps up my introduction here. I'd be very interested in any questions folks had, and also any feedback about the kind of if this is the kind of information we hope to hear about informatics in a learning collaborative, because we're also interested in improving this learning collaborative process as well. So open to any of that kind of go.